Today we are going to discuss a very important skill, which is a must know for most of the MBBS. And obviously, it goes without saying that every surgeon should master this skill set. This is a very life-saving skill set and essential for trauma, other malignancies, uh, and many other scenarios. And the skill is putting an intercostal chest tube, or as we call it, chest tube drainage. So we'll be talking about this in few things. So this is what we are going to talk about. Now let's talk about the indications of putting an intercostal chest tube. And we know most of it, but just to revise, pneumothorax, which is presence of air in the pleural cavity. And because of the pressure of the air in the pleural cavity, the lung is not able to expand. And that is why putting a chest tube is therapeutic. And sometimes it can be life-saving also. And life-saving, yes, especially when there is a tension pneumothorax. When we say tension pneumothorax, means the pressure inside the pleural cavity is so much that it is compressing the lung and also started compressing the great vessels which are there in the thorax, namely the vena cavas and then the heart muscles. And when the vena cavas are compressed, it causes decrease in the pre-return and the blood filling into the heart, and that further leads to shock. And also because the superior vena cava is compressed, we'll see distended jugular veins. So that gives us a good triad of tension pneumothorax, which is distended neck veins, shock, and absence of breath sounds on the involved side. It is very similar to tension tamponade or cardiac tamponade, which also has a triad. The only difference between tension pneumothorax and that is that in tension pneumothorax, breath sounds will be absent, whereas in tension cardiac tamponade, the heart sounds will be muffled. So that can differentiate. Both are life-threatening conditions, and in both, we should know the basic management, which will be able to save lives if we do a timely management. So here, in tension pneumothorax, immediately we have to put a chest tube if you are in hospital. If facilities are not available for chest tube, we can do a needle thoracotomy. So that is first. And pneumothorax also, if there is tension pneumothorax, obviously we have to immediately put. Also, if the patient is having a very mild pneumothorax, maybe we can manage it conservatively if we know that it is not evolving, not expanding. But if the patient has to be put on positive pressure ventilation, even a small leak, because that leak will aggravate when we'll put high pressure inside the lungs, so that air will leak into the pleura and will cause tension pneumothorax, or it can aggravate. So whenever a patient is being put on positive pressure ventilation, even a very small amount of leak we cannot tolerate, and we'll have to put a chest tube in place. In case of hemothorax, if it is, we have to put, again, if it's a significant amount, if it's a very mild amount and it is not increasing in time, we can manage it by observation alone. But hemothorax, typically after trauma, becomes an indication for putting a chest tube. Very large pleural effusion, which is compressing or causing disruption of a lung function, then we'll have to put a chest tube. Empyema means pus or presence of pus in pleural cavity. Again, we'll have to put a chest tube to drain the pus, and then also we'll send the samples for investigation. Chylothorax means chyle, or generally happens after lymphatic surgery or doing a cancer surgeries where a lot of chyle is there inside the pleural cavity. Also after radiotherapy, we can see these conditions, and then chest tube has to be drained.